Okay, welcome everybody to the sixth lecture of this series. And today we have one of our experts in the pain management, Dr. Sheng Liang. He's going to talk about low back pain. Dr. Sheng did all his medical training between New York and Pennsylvania. He got his DO degree from New York Institute of Technology. Then he went on to do his internship at Maimonides in Brooklyn. He did his residency in physical medicine and rehabilitation, and to top all off, he had a spine fellowship training at the Rothman Orthopedic Institute. So it's really my pleasure to introduce Dr. Sheng Liang to give the talk this evening. Sheng?
Thank you, Dr. Brun. So do I have to take it back from you? Oh, okay.
Good.
Can you see that?
Yeah.
Okay. All right. Welcome everyone to this evening lecture here. All right. So today we're going to be talking about low back pain here. Okay. So why should we even care about low back pain? Well, it's one of the most common reasons a patient may seek any kind of medical attention from a provider. It has a very high point prevalence. At any given time, between 10% to 30% of the population is experiencing low back pain at any given time. And pretty much everyone, nearly everyone will experience back pain, low back pain, at least once in their lifetime. So about up to 80%. The figures are 75% to 84% of individuals will experience it once in their lifetime. And this is a huge burden on our society from an economic standpoint, because a lot of money is being spent on the management of this problem. Over $200 billion is spent annually for low back pain, on the management of low back pain. And in addition, it's also one of the #1 reasons for workers' comp cases as well. And because they have lost work hours and they have lost productivity, that also adds to the economic burden as well. So the way we can kind of split this up is there are many different types of causes of low back pain, but we can split them up into 5 main categories, starting with mechanical trauma. So you can have a direct injury to the disc. The disc itself does have pain generators, nerve endings. So certainly if you have a direct injury to the disc, you can have a significant source of pain. You can also have an injury to what we call the pars inter articularis. And I'll get a little bit more into the anatomy in the next few slides. But essentially, this leads to instability of the spine and can lead to what we call a spondylolisthesis. And you can have injury, you could strain your muscles, you could pull something, and that could certainly hurt as well. And I see a fair amount of patients actually during their pregnancy or after their pregnancy, they may have a lot of back pain. So I see that as well. In the second category, we have degenerative causes of this issue. You have joints in the back of your spine. You have facet joints. So they can, like a knee joint, the way I explain it to my patients, like a knee joint, like any other joint, they can become arthritic and a significant source of pain. And that goes for the sacroiliac joint as well. Spinal stenosis is another degenerative cause. And then you have compression fractures. I'll go a little bit more into these individual diseases further down the line. And you have inflammatory causes. Those are things like autoimmune diseases like lupus, arthritis, rheumatoid arthritis, ankylosing spondylitis, reactive arthritis. Those are some names of autoimmune inflammatory disorders that may cause significant back pain. And then you also have oncological reasons as well. With the oncological reasons, it's mostly actually secondary tumors. Rarely do you actually have primary tumors, primary lesions, such as a schwannoma or multiple myeloma. Most of the cases are mets from maybe like the prostate, for example. So they're bony mets. And then lastly, we have infectious causes of it. You may have some And this is where your history comes into play, where your history taking is important. If the patient has any history of IV drug abuse, when they're sharing unhygienic needles, certainly that can lead to infection, sepsis, and this could kind of seed, essentially bacterial seeding into the spinal canal and cause abscesses. Kind of in a similar way, tuberculosis is as well. If you have untreated tuberculosis, you can actually have a spinal manifestation of this disease. And it's called Pott's disease, where you have these abscesses in the spinal canal, you'll see. So next slide here. I'm not going to delve too deep into the anatomy here, but essentially you have your vertebral bodies, you have your disc in between, you have the yellow nerve here. This is your nerve here that comes and exits at every single level from the foramen. And then you also have your central canal over here, which is very important, which is where your spinal cord kind of traverses. And the way I describe it to my patients is this is kind of just like it's like a tunnel in where the nerves run, essentially. And then you have the joints in the back. These are facet joints in the back, but those are the most of it. So whenever we talk about back pain, we have to give a little bit time to the disc. We're going to talk about the disc a little bit. So the disc actually has a natural kind of life cycle. So as you can see here on the diagram on the right here. So what happens is that when you're young, your discs are really hydrated. They're really, the way I described it, like they're plump and juicy. And when you get older, what happens? It gets dried out like a raisin, essentially kind of like a raisin. And this leads to things like disc bulging, leads you to have things like disc bulging and herniations. And that's what's kind of shown here on the right side here. So you may have some. So this is a normal disc. I don't like this diagram too much because I feel like this is more of a bulging disc, but essentially this is kind of like a herniated disc. And this is like dried out disc, essentially. So what happens is in a disc herniation, it could come, the contents, the central contents can spill out, and that leads to a inflammatory reaction causing a neuritis onto the neighboring nerve here. And then it causes a significant source of pain. Another scenario is maybe it could just be the disc is just really large. It could cause a direct mechanical pressure on the nerve, and that either of these scenarios could lead to a radiculopathy. I found this. So this was a study done in 1999. I thought that was a really interesting, very interesting study. So what this the primary investigator did here was he essentially took a pressure probe, a transducer, it measures pressure of the disc, and he stuck it into his own L4, L5 disc, which I think is crazy. And he did, and then he proceeded to undergo different positions here, and activities here. So he did sitting, he did all these different positionings, standing, he did, bending over to pick up something, bending over, sitting with good posture, sitting with bad posture. So all these readings were a result of that study here. And as you can see here, the worst thing for you is to be sitting and trying to pick something up, and that's really bad for your disc. So I thought this study was interesting. It's also kind of like the basis behind, I know like the standing discs right now are very popular. So as you can see here, if you have really bad posture, then your pressure goes up relative to the control group. So this control group was the standing, which is at 100. And if you're sitting with bad posture, you can compare that here yourself. But these are the results he found, and I thought that was really interesting. Okay, so what happens? So you get a disc herniation. What happens? Then you have this diagnosis of it may lead to this diagnosis of radiculopathy. So what does that mean exactly? Well, in a radiculopathy, how do you diagnose this? You have to have motor changes affected, your sensory changes are affected as well as your reflexes. So if you have all three of these changes on your exam, on your physical exam, then the patient has a radiculopathy. And I know these are the dermatomes, as you guys may recognize, S1, L4, L5. And then obviously the MRI should also be concordant with your findings on physical exam. It should kind of confirm that there is in fact a disc herniation at that level where you're suspecting the radiculopathy to be. Another big pain generator is the sacroiliac joint. This is actually a very large joint. This is a very large joint in the body, one of the largest joints by surface area, and it is a weight-bearing joint. It connects essentially the sacrum to the pelvis, the iliac portion of the pelvis. And if you have issues here, patients may complain of buttock pain, but not really too much leg pain. It won't shoot down the leg. It just kind of stays around the buttock area. And this is a result of injury to the joint capsule itself, or maybe the overlying ligaments. There's a lot of ligaments, stabilizing ligaments, both anteriorly and posteriorly. So a few situations where we would see this. One situation would be after a car accident. Certainly after a car accident, you can have a femur fracture as well as injury to this joint. And a second scenario would be due to degenerative changes, just plain old degenerative changes in an older patient. A third scenario where I would see this is in a younger patient. So if a young patient comes in with persistent buttock pain for maybe over 6 months, he complains about a lot of stiffness, and he also complains of maybe some GI upset or some GI problems, then this might be an autoimmune thing. Actually, it might be what we call a disease called ankylosing spondylitis, and this typically occurs in younger individuals. Younger males is what I associated with, maybe 25, a male with stiffness and buttock pain. I would typically think of maybe an inflammatory component to this disease. So I'll be thinking of something called ankylosing spondylitis. That would be the third scenario where I would see this. So what is ankylosing spondylitis? Well, it's an autoimmune disease. It has this HLA-B27 plus associations, mostly in younger individuals, and it has this kind of on X-ray, it has this very characteristic appearance, very unique, where essentially all the levels are fused, all the joints, all the facet joints here are fused. If you've looked at spine MRI X-rays, you'll know that this is definitely not normal. This is a very abnormal appearance where it's completely fused. And these patients have to see a rheumatologist. They have to be followed by a rheumatologist. They have to be maybe put on some immunomodulators such as methotrexate or sulfasalazine, and all the new ones that are really hard to pronounce, etanercept, adalimumab, and they may benefit from a steroid injection as well. So what happens if this is not treated? Well, if this is not treated, it could lead to something. It could lead to what we call hyperkyphosis. If all the joints are fused, it leads to essentially you will be very flexed. And there was this really severe case of it coming out of China, maybe like 2 years back, what that was making into the news outlets about 2 years ago, a very extreme case of it. I'm going to show you in this next slide here. So this is Folded Man. I'm not sure if anyone saw this, that was making the rounds on the news outlets, but essentially he's a very extreme case. He has ankylosing spondylitis, and he's like, I think he's in his 40s, and he was like, his whole life he had to be taking care of his mom. As you can imagine, a person being super flexed like this is not, you can't do anything like this, obviously. So this was a very, very extreme, severe case. Fortunately, this is a happy ending. This was in Shenzhen, I think Shenzhen University Hospital or something like that. But they saw the orthopedic group there, and there's videos of him out there now, of him like walking. He's like living a normal life now. So it does have a happy ending. But yeah, if left untreated, ankylosing spondylitis can lead to something severe like this. So another disease that I see pretty commonly is something called spondylolisthesis. Essentially, it's instability of the spine. There's two scenarios where I would actually see this problem. The first scenario would be a younger patient, maybe someone that does a lot of hyperextension. That does a lot of hyperextension. So maybe like classic is like a gymnast, like they do a lot of hyperextension, and that leads to injury of this pars interarticularis part of your spine, and this leads to instability of your spine. You have essentially you have shifting of one vertebral body upon another. You have the top portion usually shifting anteriorly, and you have the bottom portion typically shifting posteriorly. And as you can imagine you have the nerve here that gets caught here, kind of gets tugged on and caught, and this leads to a significant source of pain. And it's graded to there's like grade 1, grade 2, grade 3, grade 4, which is pretty easy to remember. It's like less than 25% shift is grade 1, 25 to 50 is grade 2, and then so on and so forth. But mostly when I see this problem is mostly in older individuals with very degenerated facet joints is when I would see this problem. So your facet joint disease is another very common disorder I see, problem I see. It's mostly axial in nature, which means it's more midline. It's just mostly midline. There's no radicular component. It doesn't go down your leg or anything like that. So it's mostly in older people, 65, but of course, if there is some kind of trauma history, it can present in younger individuals. And this is impossible to diagnose through a physical exam. This is purely a you have to do a block basically in order to diagnose it. You have to do a procedure in order to diagnose it. Yeah. So another disease I see very, very common, spinal stenosis. Stenosis means narrowing. So it means essentially narrowing of this central canal here, this central canal here. So you have, this is an axial view. So it's like a bird's eye view from the above. You have your disc anteriorly, and then you have your facet joints posteriorly here, and then you have your ligamentum flavum here. So all these three components, all these three structures, when they become degenerated, actually decrease the diameter of the spinal canal here. So bone spurring coming from the facet joint, the ligamentum flavum back here also gets hypertrophied, and that encroaches onto the spinal canal as well, and you have the disc bulges and the disc herniation that also encroach into the canal as well. So all three degenerative components lead to spinal stenosis. Pretty much, I always think of 65 and over spinal stenosis, 60 and below is radiculopathy is how the easy way of thinking of it. And these patients might have some claudication. They may feel like, oh, they may say the story of, oh, doc, when I walk or I stand for 5 or 10 minutes, and for more than 5 or 10 minutes, my legs start getting really tired. My back starts to get really tired. And then they'll find a seat somewhere and they'll sit down. And then like 2 minutes later, they feel completely better again. And then they walk again, and then the same thing happens again. So patients typically feel worse walking or standing, feel better when they're seated and sitting. And this actually has, there's a reason for this. It's because when they're sitting, I mean, when they're standing and walking, they're actually extended, right? So what happens in extension, in spinal extension, is you actually decrease the diameter of the canal. So that's why they don't like to be extended. It feels uncomfortable for them to be extended. They prefer to be hunched over, flexed over, which is why I'm sure you have seen out when you go out into the street, you see a lot of grannies. They're all hunched over. They all have this characteristic gait, hunched over gait. So it's because they feel comfortable like that. It's not because it's because that's the comfortable position. That's why they walk the way they do. And they usually have that's why I say a rolling walker is always the best for this kind of problem. Spinal stenosis, rolling walker is the best because they get to put their weight on it and they get to kind of just lean on it, and they could still walk. So it's the best DME thing for patients with spinal stenosis. Lastly, we have compression fractures. I do see these. Yeah, I do see these. Not uncommonly, mostly in older women because of the hormonal changes after menopause. You don't have estrogen anymore, so the bone density definitely changes. They may need some vitamin D or some kind of hormone replacement therapy. They should do some physical therapy. And here's a picture of the fracture here with what we call the anterior wedging here. So this actually doesn't really, it's not really that big of they don't need to see a surgeon or anything unless they're complaining of some kind of neurological compromise. If they have some kind of neurological compromise, they're getting weaker in the legs, or they have some kind of sensory changes, or maybe this is the vertebral body is too what we call retropost basically is moving too posteriorly. If this is moving too posteriorly, it can actually impinge onto your spinal cord here. So that's the only time we have to talk about surgery. But most of these actually kind of just go treated and patients feel better and not big deal. They typically don't require surgery. That's what I mean. Okay, so how do we treat low back pain? To summarize, so it's a pretty straightforward algorithm to be frank with you. So we do some medications, use some NSAIDs is the recommendation from Tylenol if NSAIDs are contraindicated, if they have some kind of radicular components, if they have leg pain shooting down, then I may put them on a neuropathic agent such as a gabapentin or pregabalin for patients with radiculopathy or spinal stenosis. If they have mostly axial pain, then I wouldn't do that. I would just give them like a muscle relaxer, like Flexeril, cyclobenzaprine, baclofen, and tizanidine. Have them do a little activity modification and give them a little bit education on what positions to avoid. And then of course we have physical therapy available to them as well. We have acupuncture and we have spine injections. So this is our suite. This is our physical therapy office here at 757 8th Avenue in Brooklyn. This right side, we have a C-arm. We just got a brand new C-arm. This is not a picture of our suite. Our suite is much nicer, much bigger, but I don't have pictures. Yeah. So we have physical therapy, guys, and we have pretty much everything. So everything a patient needs for pain needs. So that's it.
Okay, thank you very much, Dr. Liang, for a very instructive and informative talk. I learned something. Actually, I just saw a patient with ankylosing spondylitis, and on the modulator therapy. And does physical therapy help? Because he's a very stiff back, obviously. And,
yeah. So the important thing for these people with ankylosing spondylitis is to maintain range of motion, to maintain flexibility. As you can see from that, really, I know I chose a very extreme case there, and not all ankylosing spondylitis cases progress to that stage. But yeah, to maintain flexibility, so definitely physical therapy is very important for sure. If you have ankylosing spondylitis, for sure.
Any burning question from the audience? Dr. Leibowitz?
Hey, how are you? I was going to leave you alone, but here are a question. There was a study in the New England Journal, I think it was 2016. Not a study, it was a case report of a resolution of a disc herniation within a couple of months with physical therapy. And I've seen that on reports in some of my patients. You look at a new MRI of an old problem, and the radiologist mentions, oh, prior disc herniations have resolved. I've seen it in a couple of my patients, find it very interesting. Is there any specific technique that could enable that to happen? Because what I kind of tell my patients is, unless they have significant neurologic defect, obviously then they have surgery. I'm saying, I know it hurts. Shut up, stick it out. In a couple of years, it just may resolve itself, and don't go mutilating. Don't go mutilating yourself.
Yeah.
So is there anything specific on your end that you could do to enable resolution?
I am aware of what you're referring to. There are many, like a few studies out there that have shown when a patient, they'll get an MRI when their patient gets the disc herniation, and they'll do a 1-year follow-up. And then they'll see that most of the time it disappears. I'm not really sure exactly how many months it takes for the disc herniation to disappear, whether it takes exactly a year. I have no clue, because no one's really getting MRIs that frequently. They're not getting MRIs every few months. So there's no way for us to tell. But I'm not aware of anything. I'm not aware of anything that we pain management providers can do to speed up the process of disc herniation resorption.
Gotcha. Yeah. All right. I'll send you a picture here. Just the.
But I know what you're referring to. Those studies I have seen.
Oh, you know studies. The article. Yeah, I've seen it on a bunch of my patients too. It's funny though.
Yeah, I
no one actually.
My patients. Sorry.
No, I'm saying it's just like no one really wants to wait it out. That's the problem. They're all like, take it out, take it out. Fix it, fix it.
Yeah, I typically tell my patients, you know, it's possible that in a year it'll be completely gone. But there are cases that
Right.
it may remain. So it really, I think it's case by case basis.
Sure.
Yeah.
Thank you.
Yep.
Great talk.
Okay.
Thank
Any other questions? But with no further questions, thank you very much for your time, and thank you, Dr. Liang, for preparing such a nice, instructive talk. And it will be on YouTube tomorrow.
Okay.
Okay.
You're a YouTube star now.
All right,
Okay.
great.
All right. Good night. Good
All
night.
right, guys. Thank you so much. Have a good night. Bye-bye.